Good afternoon, everyone. Let me just introduce Dr. Beime. He's a pediatric gastroenterologist and hepatologist from University Children's Hospital in Hamburg. Welcome, everyone. Thank you for joining us today, and especially Dr. Beime for providing us with this very interesting lecture.
Yeah, hello, everybody. It's always difficult to sit in front of a computer and talk to people you don't see, but yeah, I'm glad for giving me the opportunity to talk about this very interesting topic, one of my favorite topics. And today the webinar will be about liver transplantation and Maple Syrup Urine Disease, and I will talk about specific challenges and opportunities. And I will also, or I will concentrate on our perspective, our Hamburg experience, to this specific topic, and yeah, I will touch a few publications as well, but yeah, concentrate on our experience. About myself and my background, I qualified as a pediatrician in Hamburg at the University Children's Hospital, and I got the chance to specialize quite early during my career in pediatric hepatology and liver transplantation. And yeah, my main interests are liver transplantation for non-structural liver diseases and metabolic disorders, and yeah, non-invasive markers for liver fibrosis. My conflicts of interest. Yeah, the key points of my talk is yeah, liver transplantation is increasingly performed in children with metabolic disorders without structural liver disease. And according to a paper from McKiernan from 2019, metabolic disorders now account for 20% of pediatric liver transplantation, based on data from the US and data which covers the time period between 2007 and 2017, so it might be even more than that by now. Talking about liver transplantation in a metabolic disorder always means we talk about a therapeutic option in the situation where there's another option available. In MUCD, for example, there's another way of therapy, and dietary treatment is available for these patients. So it's unlike biliary atresia, where liver transplantation is the only option children have. And so in metabolic disorders, there's always this need for balancing the option of conservative treatment or dietary treatment and the option of a liver transplantation with its advantages and disadvantages. Yeah, talking about liver transplantation in a metabolic disorder always means we need to talk about specific risks and benefits. It's a few things are similar, but a few things are indications for a liver transplantation in children, next to urea cycle disorders and organic acidemias. Once again, this is our perspective, and yeah, I will touch a few papers as mentioned before. MUCD in general, a few general facts. If I talk about MUCD, at the beginning, I would like to just share some general facts about MUCD. If I talk about MUCD today, I talk about severe phenotypes of MUCD, considered as classic MUCD. I'm not talking about mild cases of MUCD. And MUCD is an autosomal recessive disorder, and it's characterized by an impaired catabolism of branched-chain amino acids, leucine, but also isoleucine and valine. The enzyme complex is expressed in multiple organs, mainly in the muscle, in the brain, in the kidney, and in the liver. It's characterized by accumulation of these metabolites, and these metabolites, mainly leucine, are considered neurotoxic and lead to neurological deterioration and a possible fatal outcome. These patients are at high risk for long-term neurological impairment or even fatal outcome. We have a mainstay, or the mainstay of therapy has always been a dietary management with restricted protein intake and supplementation of essential amino acids before liver transplantation became available. Now, about our situation in Hamburg, between the years 2010 and 2023, we performed liver transplantation in 26 patients. The majority of patients, or 25% of these patients had a classic MSUD. One patient was diagnosed as having an intermediate form. Median age at time of transplantation were 3.3 years, with a variety, high range between 3 months and 30 years. So not only children, but also adults are included in this study. The median weight at time of transplantation were 23 kilograms, and 11 patients, roughly 40%, received their liver transplantation at an age of less than 1 year and less than 10 kilos. Patient survival was 96% and graft survival was 81%. This table gives a short overview about the graft type used. We mainly used left lateral segments, left lateral splits, but also whole organs. And yeah, as mentioned before, patient survival was 96%. We lost one patient. It was 5 years after liver transplantation, and he developed a severe multi-organ failure due to an infection with streptococci. And yeah, about organ survival, we performed 32 transplantations in 26 patients, means that we had to do retransplantation. And the main reason for retransplantation was hepatic artery thrombosis, which we consider a specific risk factor in these patients. Hepatic artery thrombosis is a specific complication in these patients. And the second reason for liver transplantation was primary non-function. Whenever patients received a second, or in one case a third liver transplantation, they were very young, at an age of less than 1 year, within the first year of life, and at a weight of between 5 and 8 kilograms. As I said, hepatic artery thrombosis is considered a specific complication in patients with metabolic disorders, because unlike patients with biliary atresia, where the artery diameter is bigger due to the portal hypertension, patients with metabolic disorders usually have a normal diameter of their arteries, and therefore are prone to develop or have a higher risk for hepatic artery thrombosis. I hope I could explain it in the right way. And this was discussed in the literature as well. And therefore, I would consider it as a specific complication. If you talk about liver transplantation in Maple Syrup Urine Disease, you need to talk about the possibility of domino transplantation using MSUD organs. The sufficient extrahepatic enzyme activity prevents domino recipients from developing a metabolic phenotype. So within our cohort of 26 patients, we were able to reallocate 14 MSUD organs to a total of 16 recipients, including 2 domino splits. This slide is about the non-surgical complications. Of course, we saw these complications, and we saw some rejections in this cohort, and we saw problems with CMV and EBV. One patient developed a PTLD. We saw some stenosis of the biliary ducts, which were treated interventionally, and one, we believe, specific complications were seizures during the first week after liver transplantation in a total of 3 patients. That's something we usually don't see after liver transplantation in other patients without metabolic disorders. One patient developed a severe complication, a severe anaphylactic reaction with subsequent hypoxic brain injury in relation to a food allergy. This is somehow related to transplantation, but maybe not a typical complication. And as mentioned before, we saw one case where we lost a patient due to a fatal severe infection with streptococci. This slide is about the metabolic outcome after liver transplantation. And it shows the plasma leucine levels at different time points. And this is pooled data from all 26 patients. And on the left, you see the untreated patients with very high leucine levels, usually at time of diagnosis during the neonatal period, very high leucine levels up to 4,000. So dietary treatment, that's the next stage. Dietary treatment is able to control leucine levels at another level, but liver transplantation is able to even to improve metabolic control even more and keep it a lot more tightly regulated, even though patients after liver transplantation are allowed to take normal protein amounts. We advise them to perform a sick day regime after liver transplantation because liver transplantation in MSUD is not able to cure the phenotype, but you really the metabolic phenotype is you take it from a severe phenotype to a very mild phenotype. But there is the risk of a metabolic decompensation after liver transplantation. And we saw one patient in our cohort who developed a metabolic decompensation after the liver transplantation during a febrile illness. And a group from the United States, they summarized 6 cases of hyperleucinosis post-liver transplantation for MSUD. Some of them received living donor liver transplantation. Some of them received post-mortem liver transplantation. So this clearly shows the potential in terms of metabolic control, leucine control, even though patients are allowed to receive a normal diet. And so this is a very important point. And if we talk about liver transplantation for MSUD, we need to talk about the impact on neurological development. And we know, independent of liver transplantation, we know that IQ in patients with classic MSUD depends on 3 main factors. And one important factor is the initial peak leucine level. It's usually during the neonatal period, at time of diagnosis. That's something we're not able to influence by liver transplantation, but we're able to influence the other 2 factors which have impact on the neurological outcome in classic MSUD. We are able to influence annual decompensation by liver transplantation, and we are able to further improve metabolic control, leucine control by liver transplantation, as shown in the last slide. So looking at our cohort, we correlated IQ and age at time of transplantation in a subgroup of 12 patients, and we saw that these factors are inversely correlated. So it shows that liver transplantation is somehow able to preserve cognitive function in patients with severe MSUD. So this could mean that maybe we should perform liver transplantation as early as possible in MSUD, maybe as early as technically possible. So this is the summary of my talk. Yeah, talking about liver transplantation means it's still a liver transplantation if you do a liver transplantation in metabolic disorders, but some things are different from a liver transplantation compared, for example, in biliary atresia. And if you go through the different stages of a liver transplantation, you realize once again where the difference is. As I said before, the indication, it's a very individual decision process, and we try to involve psychologists and metabolic experts, dietitians, and we have longer conversations with the families, of course, to balance the conservative dietary treatment versus the option of a liver transplantation and try to find an optimal solution for these patients. If you look at the operation, the liver transplantation itself, we believe that these patients have a slightly higher risk for hepatic artery thrombosis, as explained before. So that's a specific challenge in these patients. If We look at the early complications after liver transplantation, for example, acute rejections, minor infections. We always end up in a discussion within our team. We always end up in a discussion, was it worth it? Because even after liver transplantation, you know that there would have been another way of therapy. So you often ask the question, was it worth it in this individual case? And that's something the parents answers as well. So that's a very subjective balance of benefits and complications after liver transplantation, which I think is worth considering. And in the late phase after liver transplantation, you need to realize that these patients still have a risk for a metabolic decompensation, and you need to teach them in an adequate manner. And yeah, what about their perspective in life? I think if we talk to these patients and the families who receive the liver transplantation for their child, the answer is always the same. The parents are very happy about the decision, even in the cases where the parents and the families experienced a lot of transplant-related complications. But the difference for them, the biggest difference, is that they're not dependent on a protein-restrictive diet, and that this persistent risk of a metabolic decompensation is diminished. So most families would answer this way and say, okay, for our quality of life, for our daily life, situation has completely changed. And we're quite happy about it. But I think that's something we need to address scientifically in a proper way, and ask this question in a study. And we are about to summarize our data and try to measure the impact on quality of life in these patients compared to conservative treatment, of course. Yeah, call to action. Yeah, I think hopefully I could emphasize the need to promote liver and kidney transplantation for metabolic disorders, and I think we should use our ERN network for networking, and we should share knowledge and coordinate research on therapies in these rare diseases. Yeah, and as I said, one of the main questions that remains from our perspective and from our work with these patients is we need to evaluate the impact of liver transplantation in comparison to conservative treatment, and yeah, try to measure this quality of life. Yeah, and of course, I can recommend the meeting in Coimbra next month. Yeah, thank you.